with you all. Thank you, Sherry.
No problem. Eddie is mobile, so I do have the slides up and ready to go whenever you're ready. And I also have the email that you sent with the Word document. So just say the word and it'll be done.
Great. Diane, thanks for coming. It's good to see you. It's good to have you here.
Oh, thanks. Happy to join.
We have a kind of a new member here. Diane, you want to just really briefly introduce yourself and let us know how involved you are with the perfusion community.
So I'm Diane, and I work at Johns Hopkins. I'm not a perfusionist. I'm director of informatics, and I'm also co-founder of the Maryland Cardiac Surgery Quality Initiative. And so my role is really to work with the providers in getting data from Epic and other legacy EMRs, linking it to STS registry data for outcome reporting. And I don't really work or have not designed a perfusion dashboard. We're not quite there yet, but have been interested in the Perform registry and have been talking to Donnie Wachowski in Michigan, just kind of following where that's going. So I know a little bit about perfusion, but just been sort of involved from a registry quality and research perspective.
I'm going to respectfully disagree. I think Diane knows more than just a wee bit about perfusion. But it's great to have her perspective along with Eddie's when it comes to the data portion of this and kind of making sure that we're driving in the right direction. I want to take a second here and tell the perfusionist on the call. I don't think Mindy's here. She may have been stuck. She may have gotten stuck. Happy Perfusion Week.
Yeah, you too.
Yay. It's kind of weird how it wrapped around the weekend, isn't it?
Yeah, I was like, only Perfusion would have it through like a Thursday to Wednesday.
Yeah, some weird stuff. But anyways, if your hospitals or your programs didn't celebrate you, then we celebrate you here. So we're thankful you're here and thanks for doing what you do. Okay. So Sherry, let's pop it up. Let's go ahead and do this thing. I think the first thing that we probably should do is just for the last time here, before this thing gets in the mail, is make sure we all know who's going to get. Hey, Mindy's here. Hey, Mindy.
Hey guys, sorry.
Oh, all good. We got two in scrubs today.
Yes.
Hey, Mindy, happy Perfusion Week.
Hey, you too. You too.
Thanks. So yeah, I just want to firm up and make sure everybody knows who is going to get the this slide deck. And I'm pretty sure Eddie had suggested and Sherry that it go to all of the respondents from the survey. And yes, that list as well. And then Sherry, correct me if I'm wrong, but I think you and Eddie were thinking that we would send this out to the VCSQI perfusion group. And then were you going to link it on the website, on the VCSQI website as well?
Yes, it'd be great to do a marketing kind of pitch. Hey, guess what the Perfect Care Goal-Directed Perfusion Group is doing? Check us out. So that we've been getting a lot of traction when we do things like that. So that'd be a good opportunity to show what's going on. Okay. And then Diane, I think, that's an invitation to you as well, since we had so many Maryland respondents to follow up the way that you think best to get that out to the Maryland folks.
Okay.
But it will go to all of the respondents. And so at least, all of those Maryland folks will get it. Anybody else have any comments about that list or think that it should be broadened in any way?
No, I think it's great.
Solid.
Yep.
Okay. All right. That's what we'll do. And then, so we'll pass through these. I know you have all seen them now 3-4 times or so. Thank you so much to the folks that took a second to read through them and submit your comments by email. Really appreciate that. The suggestions were great. Rachel, we're catching you unaware here, and feel free to, let's see, I guess we can maybe we can send these by email to Rachel specifically, since she hasn't seen them before, and give her an opportunity to comment on them as well. Okay, this was a survey that was distributed to members of the NCSQI, the VCSQI, and the Perfect Care Network down in North Carolina. Next slide. This is the response that we got by state. And then we took all of the respondents and created a volume group or case load group, which are the yellow slides at the bottom. The next slide is a clinical practice reference sheet or card. You can see that we used 1, 2, 3, 4, 5, 6, 7 different references, all of whom should be within the reference list on the bottom, hopefully. 1, 2, 3, 4, 5, 6, 7. Yep. The last thing we added here on the right-hand side of the slide, guys, was a separate European clinical practice guideline that I just had not bumped into before. And I found it a couple of weeks ago, rifled through it, and was able to add this as another reference. And you can see the 1, 2, 3, 4 different references or recommendations that were similar to what we had on our practice survey. And then you'll see as we go forward in the slides that we have actually, yes, thank you, Sherry. You can see that what we've done here is added this little box on the right-hand side of the slide so that you don't have to continuously flip back and forth to that reference slide, and you can see essentially the same information for each practice. And so for DO2 as a measure of perfusion adequacy on pump, you can see that that particular practice was either recommended by or referenced by each one of those papers or sets of guidelines. AMSECT, VCSQI, which is an AKI guideline, that protocol that we put out in 2023. The PREVENT document is a clinical practice guideline. Sherry, we should add CPG to that one if Eddie can hear us, or the AI picks up on that. That should also have a CPG on it. Then the MUSC University of Michigan was a survey, and then there's the European study there as well. Rachel, I know how your brain works, and so please do, if you don't mind, take a couple of minutes and go through these explanations that are in red on these slides and make sure that we got that right, because we have all been through that and made sure that they were both kind of user-friendly and yet thorough in their explanations. And you know, we talked about taking those explanations off, but then the majority kind of determined that they wanted to leave them on so that non-perfusionists, in other words, like Diane and Judy Smith here at UVA and some other folks that may be looking through this data, can have a good reference point to what this practice actually means on bypass.
No, I love
Okay.
the explanations. That helps. I appreciate them.
Great, great. Okay, next slide. So then what we do is for the next, we put up a overall group response, and then we break it down in the following slide based on states, Maryland, Virginia, and North Carolina, and then based on caseload, low, medium, and high. Brandy's suggestion, one of her suggestions, was that we actually kind of change the shades of these slides so that your eye went across instead of, or horizontal instead of vertical, which was a great idea.
Do you think the color gradients are different enough? Like now that I'm looking at it, the green and the yellow look pretty close.
Yeah,
Yeah, they look a little bit like, hospital green and hospital yellow. I do think it could be a little more
I think they were a
prominent.
little more different the first slide where you had all of them up. like the yellow was a little brighter maybe.
Mhm. Yeah. Hey, Eddie, by the way. Okay, so maybe we can, yeah. Okay. The next practice is A&H. Again, same format. Practice recommended by or referenced by the Perform group. That AMSECT is also a clinical practice guideline, so that could have a CPG over it. And then the MUSC, University of Michigan survey is right. Okay. And then again, the breakdown between states, respondents, and case volume. Okay, next, please. RAP, pretty standard at this point. AMSECT standards, Perform. That AMSECT patient blood management, again, could have a CPG over it. And yeah, okay. Very good. That one looks good to me. And next slide, please. That can have a CPG again, the AMSECT patient blood management. It's a clinical practice guideline. Okay. Viscoelastic devices, the dreaded word that I can never say correctly when I'm up in front of a crowd of people. It always comes out garbled. Pretty sure I garbled it at the quarterly meeting. Sherry went back and played the played the recording. Probably sounded terrible. Okay, and next one, transfusion trigger. Yep, perfect. And lastly, yep, very good. Okay. Yeah, and the recommendation, the recommended or referenced by, is different for each one of those three, but in each one of those, well, obviously Perform recommends and is referencing a regional database participation, but in the MUSC survey and in the AMSECT standards, it recommends participation in regional perfusion database and quality programs. Okay. Yep. So this is really, and Terry, I don't think Terry's with us today. I think she said she was going to be out of the country or something, which sounds super interesting. But one of the things that Terry brought up was a conclusion slide, and I don't think she's wrong about that. This is really kind of the only thing that I drew up, and it is not conclusion at all. I think the reason I didn't go to that place is because I don't feel like we've concluded. I think this is an opening salvo. It is simply the opening report of this practice survey. But if you all feel strongly that we need to draw it up in some way, we can do that before we hit submit or hit go live on it. But this to me was an interesting comparison between the MUSC survey in 2020 and ours in 2025. Obviously, they're not exactly, they are similar, but not the same. The MUSC U of Michigan survey was much larger. They surveyed mid-Atlantic all the way down to the southern states and all the way up to the northeastern. I think it was AMSEC District 4 or something, guys, AMSEC folks that know. I think it's District 4 or Section 4 or whatever that is. Their response rate was actually lower than our response rate, but they had more respondents. And so they did a pretty deep dive with their data. And I felt like it was an interesting look at from 2020 to 2025, how some of the responses have changed. I think, is that the end? I think that's the last one, right? Yeah. Okay. So I didn't hearing no substantial suggestions or changes. The slides are now accepted. If we're going to follow Robert's rules. And then I wanted to spend a little bit of really the majority of what we have today. And if we finish early, that's all well with me. Talking about step 2. And so this is what I just kind of came up with off the top of my head. I think, and Diane, here, this is your cue, okay? Because at a previous meeting that you attended, you reminded us that, you know, connecting these practices to outcomes is very complicated, not simply because, you know, as we all know, our practices are not, we cannot draw a straight line from practice to outcome. Perfusion just doesn't work like that. But furthermore, because of access to data and our ability to cross state lines and cross between organizations with data. But we can, I think, draw some limited conclusions based just on the practices themselves. So my one thought was, tell me what you think about this. One thought was to divide all of the respondents into 2 separate categories. The high level adopters and then the low to moderate level. But we have to rephrase that because I don't want to call anybody low. That just sounds pejorative and bad. But something along those lines. And then, you know, determine, first of all, what qualifies as a high level adopter. I don't know. I am crossing my fingers to have access very soon. Eddie and Sherry, I think I'm going to be able to set up a meeting with one of our faculty here for the implementation scientists. So cross fingers. But I don't know what the answer to that question is. And then B is, should they be arranged according to their level of scientific significance? C, if we arrange the practices, does that change characterization at a high level? In other words, if we have 2 practices that are class 1 level A, but you only adopt those 2 and not the other 6 or 7, are you still a high level adopter because you adopted the practices that have the highest level of scientific evidence, right? Or is it simply a matter of, did you adopt greater than 50% of these practices? So that's something to think about. If we go about and if we want to consider that level of parsing into the data. And then I also thought, I looked at the list of, so moving on to B here, I also thought we could take the practices, and I think all of them would fit fairly neatly into one of 2 categories. One is minimizing hemodilution, and the other one is circuit and patient monitoring. And then would it be interesting to see that, you know, a certain category or a certain number of respondents were more likely to have adopted the category A than the category B, et cetera. yeah, I kind of get lost in the weeds with that one. So I don't know how
Do
you
you
guys
have
are.
based on the data, do you have a sense of um, like what hospitals answered a certain percent above on more than one practice?
Yeah, I mean, we can get to that.
So like you have DO2, like are in terms of how to define your high level adopter, are you doing that on each measure or are you doing it on 2 or 3 measures? So like if you say DO2, you know, of all the respondents, how, you know, how many did DO2 and ANH or something like that? I mean, do you, yeah, that's kind of what I was thinking.
Yeah. So that's what that's what we've shown, is, you know, which one of the respondents have said yes or no. But beyond that, like what the frequency of cases that they use that practice, right?
Right.
And so, but I think if we look at the list as a whole, you know, again, for B, for option B here, I think if we look at the list as a whole, let's see, let's just put down the list, right? It's DO2, it's RAP, it's ANH, it's hemoconcentrator. What am I missing?
Transfusion trigger,
Trigger.
viscoelastic.
Yes. See, it's hard to say, right?
Yeah.
Okay. Yeah, let's just go with that. So we got 1, 2, 3, 4, 5, 6. And then the other one was paper charting, and that one really is not pertinent here. Right?
Actually, what are we missing?
1, 2, 3. Oh, CO, cerebral
DO2.
oximetry.
Yeah.
Right.
Because what I'm wondering if there's programs that maybe not on all of their patients, but on the appropriate patients, they do 1 through 7,
Yeah.
right? But, you know, 5 out of the 10 centers may do DO2, but 80% do ANH, but some do more than 1.
Mhm. Well, I think we should, Eddie and Sherry, correct me if I'm wrong about this, but we should be able to go as far as, let's just say for DO2, we should be able to parse out the institutions that use it most of the time. Like, I think whatever the percentage was, greater than 90, greater than 80.
So 64 was sometimes and 24.
Yeah.
No, 64 always, 24. So if you would lump them together, that'd be 88% sometimes or always used
Right.
DO2.
And I think I could, again, this is all stuff that we have to parse out, right? But what do you guys think about if a center reported that it used that practice 90% or greater of the time, I would say that is an adopter of that guideline.
Mm-hmm.
And the only reason that we don't say 100% is because in perfusion, hardly anything is. But that is an adoption and a belief in that guideline. Somewhere in the middle is what seems to me like a possibility that based on your surgeon staff, you have some adoption and some not, right?
Mm-hmm.
So it's either based on a case or it's based on surgeon protocol. But if we take those respondents for each of those that are at the 90% or greater, that center to me is an adopter of that program. The folks that are the sometimes and occasionally, that we have to think about a little bit more. But I don't know. I mean, do you think that the practices should be weighted? That's essentially the question about the level of scientific significance. Should they be weighted?
Well, clinically, do you think they should be? As a perfusionist, is one more important than the other?
Well, I think that, yeah, I mean, Diane, that's the question, right? You jumped right to the question, but I mean, to be honest, some of these do actually have, class 1 scientific recommendation.
Yeah, but I mean in terms of what you're seeing in the results of this survey.
Well, we don't have any connection to outcomes here, right? Or to clinical yet. I mean,
Right.
we can get down to option C down here in the bottom. We can talk about that a little bit.
I mean, what Eddie could do, maybe, Eddie, I'm speaking for you, but you could sort of dichotomize, since you have a never category, right? You could look at outcomes of a center who never does it versus outcomes of the centers who seldom, usually, or always do it because there's some presence of it, right? And then see for is there a difference? Of course, I don't know what the N is on the never, but you could just run just some descriptive stats and see if there's a statistically significant difference on an outcome in, say, isolated CAB or all risk adjusted cases, or all
Yeah.
cases.
Yeah. I mean, I think you're thinking exactly like I am, Diane. My concern is with the N here, which is, I think, why I was wondering if we could clump them into 2 categories, and then, we have a better chance of having a better N there, I think.
Yeah, I agree with that because especially on some of the charts there, like for instance on hemoconcentrator, there are no like nevers there. On some of them, there are very few, always responses as well. So I like that idea, Eve, just in terms of maximizing our sample size here.
Mm-hmm. Yeah, I think we have to do that in order to get a halfway decent number. Does anybody object to me traveling down this road a little bit, and then when we meet the next time, maybe having something to show for it? Does anybody see this as being time wasted, or, well, you're going to be reluctant to say that to me, but that's not fair. Do you think we get anything valuable out of that effort?
Well, I think you have to look at the numbers to see, how, I don't know what kind of numbers you have, but I mean, Eddie, even if, like, looking how you're defining always, usually, and seldom, you really do have 2 groups. You could look at the always and the never, right? Because then you have really 2 true dichotomous groups. Or you could lump the seldom, usually, or an always, or usually always, and say, kind of approximately. So I think you have to look at the numbers. And Eddie has access to that. So, I think you need to know that, because you could really go down the wrong road if your numbers are so low. Like,
Yeah.
there's only 2 centers that are never.
Yeah.
What does that mean? And are those centers high volume or low volume? That's the other thing.
Mm-hmm.
You could be a no in a very low center, and then that really wouldn't weigh much. Like, get back to the point about a weight assignment.
Mm-hmm.
Or it could be a never, but they're doing, 1,500 cases a year.
Yeah. I mean, that's, I should have added, I'd like to add another letter to the list here, a capital D, I guess. And that is, let's see, how do I want to say this? Is there a significant no, that's not it. I need AI. I need AI. Do high volume centers are they high adopters? Do you see what I'm saying? Do low volume center, is there a significant difference in guideline adoption between low volume centers and high volume centers?
So
Did I get
to
there?
to make it simpler, kind of, I have to do things very simplistic to kind of get things in my head. But if you were to list all of the centers, in a column, and then you listed all of your the eight,
Practice.
measures, DOT,
Mhm.
right? And you put a little, and you have a criteria whether you're going to do, yes, and you put a little check mark. You can kind of visually see, and you can kind of like mark which center is high, low, or medium, right, Eddie?
Yeah.
Because you could rank them in your rows, aggregate all the low, medium, and highs together, and then put all your metrics, and then visually you can see where all the check marks are, sort of the concentration of the responses to
Yeah.
make you think about what the next questions are.
Yeah. I mean, I think that might be interesting as well. I got to be honest with you. I think we might be surprised to find that the lower volume to moderate volume centers might be higher adopters. But
Just
that's
because
just
it's
an
easier
opinion.
to change policy at small centers, you think? Whereas larger centers, it's hard to change an entire policy.
Yep.
And I think because large centers, there's a high number of perfusionists, so there's a lot of variation. And in our
surgeons.
study, yes, and surgeons. And our study, when we looked at it in Maryland by perfusionists, I mean, the variability among perfusionists within one center was eye-opening.
Yeah.
And it wasn't just, and even at Johns Hopkins with our perfusionists, when we go back and look at data, the perfusionists may practice different, but they also document different.
Oh, yeah. Yeah.
So, you have practice variation even within a program.
Yeah. Yeah. 100%, Diane. There are no straight lines hardly in perfusion. It's all squiggly lines. But yeah, Rachel, I think that's a great point. That, it just become a strong leader in the perfusion department or in the surgical department can, affect change in a way in a smaller place without having to go to 5 different committees for 4 different approvals, so that's a good point. Okay. So thank you for adding on that. Let's, with the time, I want to be mindful of our time here. I'm going to meet with Eddie. We're going to start looking at these options. Eddie will help us to understand and make sure that we're keeping value in the results and not just, wigging out on ideas that kind of lead to nowhere. Because he always does that for me. So let's let option A kind of lie for a minute. How do you all feel about categorizing into 2 categories? So DO2 would be monitoring, right? RAP would be hemodilution. ANH would be hemodilution. Hemoconcentrator would be hemodilution. Transfusion trigger. I don't know. Viscoelastic devices. Kind of both. Huh? Monitoring more than the other, probably. Cerebral oximetry, monitoring.
I think trigger would be hemodilution and the elastic would be monitoring. I agree.
Okay. No, hemodilution. Yeah. Thank you.
And this was hemodilution or monitoring? ANH.
Hemodilution. So we have 1, 2, 3. 3 monitoring and 1, 2, 3, 4. I don't know. I think I'd like to kind of pull those numbers up and see if it's interesting. And if it's not interesting, then we let it drop. You guys good with that?
Yeah, I agree with that.
Eddie, do you know how many centers in Virginia participate in the STS anesthesia registry?
Unfortunately, we're 0. Yeah.
0. Okay.
Big
Just
0.
because they really have the data fields for ANH, you know.
They have so many data fields, Diane. It just makes me drool to look at that form, but nobody
Yeah.
uses it.
Just wondering.
Yeah. Okay, and then let's go to C, please. And now we get to something that may be the most compelling, which is for Virginia and Maryland, if Diane thinks that she can, oh, sorry, the big letter, capital C? Yes, thank you. Can we demonstrate any significant patient outcome differences between hospitals based on guideline and standard adoption? We can, again, just because of the N number here, I think, Eddie, please chime in. This might be another circumstance where it's better to clump the practices into high versus not high, and then see if we can get some numbers on certain patient outcomes. I don't know. What do you think?
I think it depends on the practice, and we can try a couple different ways of combining them together, but I agree with that approach, Eve.
Because I mean, let's just play the game and say we look at UVA and we say UVA is an adopter of DO2 assessment and tracking during bypass, and then UVA's AKI rate XYZ, their blood transfusions XYZ, length of stay, whatever. I
think you can do that.
We are now creating an entire slide deck for each, responder. It just seems like a lot of work to me.
No, I don't. So we kind of did this, Eddie. Remember when we looked at different things in STS outcome, and not to this degree, but if you were to take all of your programs that said, yes, they did DO2, and all the ones that said no, because then, eliminate the ones that you really don't know. And then you can look at their STS data because you're saying, yes, they did DO2, as long as it's the time frame, like, did they do DO2 for the last 10 years that you have data, or just like the last 5 or 3 years, right? And then you could really link the practice of DO2 with AKI because you know that it was done on every patient.
Yeah, should we do it as in a category as adopter versus not, or I mean high versus moderate to low?
I think it depends on the numbers. We really don't know the numbers. We only have percentages. Right. And then those numbers depend on the size of, the program. I think Eddie's more familiar with all the programs and their volume than me, but I think that might be a little tricky. You have to look first.
Well, Eddie, we can. I think this will be for the for everybody in the VCSQI, I'm just envisioning a quarterly meeting for us, right? And I can envision a presentation that Brandy is going to give at the VCSQI. And, linking to outcomes will be what catches people's attention, I think. Like the perfusionist in the room will love, just the practice slides that we've presented. But I think for those other folks in the room, so
Because really what you want to
will the
say,
committee commit to allowing Eddie and I to do some preliminary work on linking outcomes and kind of see what we can come up with? Does that seem reasonable? Now, this is just for Virginia. I'm sorry, Mindy. Is Mindy still here? Or she bugged out? She bugged out. Oh, Shannon's here. Hey, Shannon.
Mindy texted me. I told her I would do everything I could to cover, but she had to go to an emergent case. So
Totally
she said
understandable.
she'll come back on when she gets things set up if we're still on.
Right. Well, and we've talked about this before, Shannon. We understand that, if the VCSQI and maybe the MCSQI decides to do some of this, take some of this data and create some outcomes, we understand that Perfect Care would not be able to do the same work. But we think that it's going to be helpful you in the long run in your efforts to continue to organize, because you can show that the depth of information you can present to your practitioners. So we don't want to we don't want to leave you out. We hate that.
Yes.
Yeah.
but Eddie, as it stands, VCSQI won't combine data with MCSQI. Is that right?
For publishing, but I think for a quality project like this, we can, to me, I don't see a problem with that.
Yeah, I mean, it would be a de-identified data extract of MCSQI and VCSQI, right? With an identifier of the collaborative and then an identifier of the hospital as being 100% DO2 or 0% DO2, right? Based on those numbers, though.
Right.
And then did you want it for all pump cases, or did you want to narrow it down to select like risk adjusted cases, or just, isolated CAB cases?
And Rachel and Brandy, what do you think about that? I have my idea about that. I think, and Rachel, I'll just preface that by saying that if you glance through some of the VCSQI current metrics, they are generally limited to, for instance, like cabbage only cases.
I'm torn because not a lot. Some of these we only do on our more challenging cases. So I feel like you're going to make us look like we're not adopters when we are. We just only adopt on the higher risk. So when you're dealing with a topic like this, it's hard to weed out the challenging cases.
I think you almost have to separate them, like cabbage and challenging cases. And I think you'll get different responses from hospitals based like that too, because some of the smaller volume might not do as many challenging cases.
Well, how are you defining a challenging case?
I guess mine would be like your emergencies, like your type A's or valve cabbages or multiple valves versus just like a cabbage valve. Or your redos, those are challenging.
Like we only do our tags on our redos, our aortic dissections, our multiple valves. We don't do tags on any other patients. So that would be one that we'd not show up as adopting if we didn't do more than just cabbages or cabbage valves.
Rachel, do you happen to know if your center responded to the survey? It came out a while ago.
I unfortunately don't know. Do you know who it would have been sent to? Because that's how I can get you the answer.
Sherry, can you see if Carillion had a respondent? Or if they responded to this?
I'll double check, but I'm pretty sure Carillion did respond.
Okay.
Yes.
We had the same issue in the Maryland when we surveyed individual perfusionists. They found it challenging to answer the questions just for this reason. Like, what kind of cases are you asking me about? On dissections, yeah, we do it on all of them. but on an isolated cab, or, no. You know what I mean? We may not do it all. So that was
Right.
a little bit
And-
fuzzy.
Right, which is why we gave each question the opportunity to respond, 90% or greater, meaning we just do it all the time. Or
Right.
some, the gray space in between, which was generally, maybe 25 to 80% or something like that. It was defined in the survey. Right now,
Okay.
my mind is blanking, but it was defined in the survey. And then the nevers were like less than 20%, meaning it's really not adopted, but every once in a while, randomly, we just do it.
But all the
Um,
time, all cases, or all the time when it's appropriate?
All cases, all
Okay.
adult cases.
Okay.
And so it does not differentiate between an emergency dissection and a cabbage times 2, an elective cabbage times 2.
So I think if we
But-
get results based on that, we shouldn't really split them up, right?
I vote leave them all together. We all have bad cases. I don't think it's going to make any of our numbers look worse than other people if that's what we're worried about. But that's just my opinion.
So then what that would mean is that if it's all cases, Eddie, correct me if I'm wrong, that's going to mean that we're looking at all of the STS major 7 categories. Ruh-roh.
And do we want to include, the dissections and the other cases in there as well? If we're doing all comers.
Yeah, so it's going to be all of them across the demographic slide that we have, right? From cabbage to primary valves to
Yeah,
valves
all-
cabbages.
all on pump.
Yeah. Well, yeah, let's just start with you, Brandy, Rachel, and Mindy gone, Shannon and Diane. I don't know. I feel conflicted about this question.
So let me ask
The metric designer in me for the perfusion metrics that we put out says to look at like things. But I take Brandy and Rachel's point that just looking at cabbages, well, let me just say this. If we have asked the question and the respondents have answered the question based on all adult cases, and then we tie it to a segment of data that isn't all adult cases, then we're flawed. So now I'm changing my mind.
Yeah, that's how I'm picturing it.
Okay.
Mhm.
Okay.
Is there a center that would do DO2, ANH, RAP, all of these on all isolated cab cases?
I don't know if you could say that there's a center that would necessarily do those 3 things, but there
Okay.
are definitely centers that do DO2 100% of the time.
Okay.
And then there are centers that do, let's just take like cerebral oximetry, which seems to be kind of one of those, no straight lines here, just squiggly lines, right? And so a lot of centers will monitor cerebral oximetry on certain cases, mitral valves or, whatever, but they won't throw it on for an aortic dissection. And so that one is going to be one that is a little more wishy-washy. And as Rachel brought up already, they're only doing viscoelastic device measurements or tags, she said, on certain cases, not on all cases. Whereas other centers like ourselves, we do them on every case. So I think everything needs to go in the pot because that's what we asked on the survey. We didn't say cabbages only. So we need to make it everything. Okay. Okay. This is a good start for us. Eddie in his spare time. That makes me laugh because he really doesn't have any. And yet Eddie and Sherry have devoted a lot of time and energy to this particular group. I think they see value in it. They see value in you all showing up every month and talking about this and having discussions. We've tried
Absolutely.
other kind
We
of try.
absolutely do. And I'll just jump in. I'll say I was just meeting with one of our surgeons actually over at VCU, Brandy, and he mentioned that he has loved to see the perfusion involvement in the group, and just that you all are adding a lot of value here, and just to keep going and do what you're doing, because it's helpful. So just wanted to let everybody know that.
Awesome.
Yeah, I hear the same thing. And the whole goal of being in the VCSQI and trying to create in this tri-state collaborative is to put our names along with all the other folks that are contributing to the science and the data, and make sure that other folks know we can play a part. So that's what you are doing.
Eddie, do you have a sense of the number of programs in Virginia that use specialty care?
Eve, what do you think?
Yeah, it's a lot, Diane. I don't know an exact number, but I think it's, Brandy, maybe you can help out. I think it's probably between 5 and 10.
It's a lot. That's all I know. I mean, besides
Yeah.
the VA and us, every other Richmond-based hospital is specialty care.
Mhm.
The,
So
the
that's
reason I
three.
asked
That's three, and then I think a couple over on the coast as well.
Yeah.
And if it's not specialty care, I think there's a couple of folks who are now what's the other guys? What's the other perfusion staffing?
Keystone.
Yes, Keystone.
You want to bring a toy?
the reason I was asking is
That was
because,
Rachel.
specialty care has their own database.
Mm-hmm.
I do think they enter the STS case type, but I'm not sure. And Maryland, I think there's only 3 centers that use specialty care, Eddie. They're really the private community hospitals, not really high volume though. And just thinking maybe as sort of a subset analysis is, and maybe bring Perfect Care in if they do specialty care, but get specialty care to run a report on those hospitals within the 3 collaboratives.
Yeah, that'd be an interesting conversation. I don't know who to have that conversation with, but that's something to keep in the back of our minds for down the road. I know they have their own database, and they're possessive of that, and they're very active with it. It's not like they're just sitting on it, not doing nothing.
Yeah.
They're creating a lot of information and a lot of literature for perfusion, which is fantastic.
Yep.
I think I can say this. I'm fairly certain that we had some specialty care respondents because we did not ask them, specifically for data. We're just talking about practices. So I think I'm right about that, which was great. Okay. Again, thank you for coming, for contributing. Rachel, since you're the newest to the group, please reach out to us if you feel like you need to catch up with something or want a better understanding. If you have the latest perfusion metrics or don't, reach out, just email with Eddie and Sherry, and they'll send those right to you. And you can start browsing through those and helping us to improve that set of metrics. They go out to everybody in VCSQI. And let us know if something pops into your head that you didn't think about today. Otherwise, Eddie, I think we have our work cut out for us. And how about this? How do you guys feel about meeting over the summer? Do you want to continue to meet every month?
I'm fine with that.
Okay. All right, Eddie, 4 weeks.
Good to meet whenever. Sorry, I didn't see.
That's okay. You're handing out toys. All right, we'll do it then. 4 weeks. Eddie and I will get together. We'll try to dive into some of these things and come up with some preliminary results. Meanwhile, the slides go out. Sherry, hit the send button. We're good to go.
It's good. Consider it done. I will send it out. And I'll
Outstanding.
have the blast before the end of the week on the website.
Perfect. I'm really looking forward to it. And I hope you all will kind of put the word out. And next time we get together, let us know if you had any reaction from the slides. Sorry, we didn't do this. What do you guys think about putting up just not a survey, but actually just one follow-up email to everybody that get to all the respondents and sending them to just an open text box that says, leave your comment here, instead of like sending email chains and emails, flying around and stuff. Maybe.
Good idea.
Yeah.
Just something that says, leave your comment here. And then if we get a lot of feedback and we get comments from people, then we can think about, and I know Terry has suggested doing a Zoom meeting with respondents, but let's see if we get any comments first before we set up a meeting. And then we're all just sitting there looking at each other. Yeah, I've been there, done that. It's not a great feeling. So this is what I was thinking is, let's see if we get any comments or any feedback. And if we do, then we can push it the step further. Sherry, do you think that's a good idea?
I think that's perfect.
Great. Thank you so much. See you all next time. Hope you have a great week. Happy Perfusion Week.
Yeah.
Thanks for letting me join. I appreciate it.
Love
Thanks, Sarah.
having you here, Rachel. Thank you.
Bye.
Bye.